Welcome to Looking at Lyme, an educational podcast of the Canadian Lyme Disease Foundation, designed to increase awareness, empower listeners with expert knowledge, and explore solutions. I'm Kim Cairns. Dr. Kendall Soucie is an associate professor in the Department of Psychology at the University of Windsor in Ontario, Canada. She studies women's health, particularly the social and institutional impacts of living with chronic health conditions that primarily affect women. Marissa Rakus is a PhD candidate in the Applied Social Psychology program at the University of Windsor. Her research examines gender-based violence and women's interactions with formal support systems. Together, they are researching medical gaslighting. They've been gathering information from respondents and have compiled close to 2,000 responses from women who say medical personnel have not taken their problems seriously. They join us today to talk about this challenge and how it impacts chronic health conditions like Lyme disease. Thank you so much for joining us today. We're very interested in your research on medical gaslighting, especially as it relates to Lyme disease. Can you tell us what medical gaslighting is?
Medical gaslighting specifically are experiences where patients are invalidated, they're not taken seriously, they're dismissed by healthcare providers based on the symptoms that they're experiencing or the concerns that they bring forth to their doctor. And it oftentimes is when providers are attempting to convince patients that what they're experiencing is all in their head or it's not real. So generally it's this idea of diminishing a patient's reality and what they're experiencing, making it seem to the patient that it's not real what they're experiencing. So putting the provider's knowledge and power of their medical expertise over the patient's lived experience. That's what makes it a little bit different than patient-provider communication per se. It's that idea of putting their reality and their knowledge above the patient experience.
How does this happen? Why do doctors do this?
The biggest part of medical gaslighting is that power dynamic. It's not necessarily about whether the doctor really has the knowledge on that topic or not. The medical system has kind of been built on this idea with this biomedical model that the provider has the power to decide whose reality is more credible than the other, right? So the provider is supposed to have this knowledge, whether they do have this knowledge or not. So there's this pressure for them to have their expertise and have that put over the patient experience. So a lot of it has to do with that power dynamics and that relationship, whether the provider is intentionally doing it or not. So it can be intentional, it can be unintentional. A lot of the times it isn't intentional.
We started a research study back in November to kind of look at these experiences of medical gaslighting. And we're kind of going through the data. And I mean, at this point, we have over really like 2,000 responses in a very short period of time. Folks had a lot that they wanted to share with us and tell us. And I think just sharing their story has really illuminated and I think ignited this conversation in our research lab and of course across different platforms as well. It kind of goes back to, we think that folks have really good intentions, and sometimes there is a potential knowledge gap, particularly with chronic health conditions that are contested or understudied. So we focus on women's health, which again is heavily underfunded and understudied. So it could be a knowledge gap. It could be, just this quick rush to like get a diagnosis quickly rather than saying things like, I just don't know, right? Like if you don't know, then there's potential for referral, there's potential for more conversations. Several of the participants who've responded to our survey will say, like, it's okay to say that you don't know, right? It's just, we want this to be a partnership. We want the investigative testing. We want to kind of go through that process to definitively know whatever it is that's causing these particular symptoms. And the other point Marissa made too, it's that embodied knowledge, right? Like we know our body. I've lived in my body for many, many, many decades. And we know that something isn't right. And we're not going to stop pushing until we sort of get there. And we want that partnership. We want it to be like an actual partnership conversation. I'll work through this with you. We'll figure it out together. Many folks they feel really abandoned by the medical system. They feel sort of left alone. They feel like they're on their own to try to figure this out. And as an example, I don't have a medical degree, right? Like I am in a way beholden to and relying on my healthcare provider to navigate that system with me. If I'm already hitting a brick wall, right? And I'm already being told that it's just stress, it's in your head, it's whatever, or it's due to something, else that's potentially not a physical or physiological issue, then you're sort of left suspended in that uncertainty. And that's a terrifying thing for folks who are struggling and unable to function. Like, we're talking quality of life, we're talking being unable to work, being unable to do things and participate in ways they want to because these symptoms are so debilitating.
Being able to talk about only one issue and for 15 minutes, that's a reality for a lot of the patients across this land.
Big part of it too, like specifically with the Canadian healthcare system, because providers are so overburdened with the amount of patients that they have and with the lack of providers that we have and just having such a limited amount of time that they can speak to patients. I think that's another mechanism that's contributing to medical gaslighting, specifically in the Canadian healthcare context, because providers are almost using it as a tool of, I'm just going to talk to you for this short amount of time and I don't have enough time to provide you all of the information that I can, so I'm just going to brush you off and send you on your way. So like I said, it's not always intentional. It's that they're overburdened, they're overworked, and there's so much pressure within the job that they don't have enough time to really sit down with a patient like some specialists can sit down with a patient for an hour to talk about everything and make it a collaborative process. But a lot of providers right now, just because of the state of our healthcare system, they don't have the time to do that. It's not even just looking at it from the perspective of the patients and how it's affecting them, but it's like, how is the system also affecting providers in ways that are causing them to act like this towards patients?
How do you both feel about adding to the medical community by having nurse practitioners as part of the process for a lengthier discussion?
In our data, actually, that we've collected, nurse practitioners as the frontline person has been just a game changer for patients because you can spend more time, you can address your, concerns. Those are conversations we are having, we want to have, because I think that we also need to understand, like Marissa was saying, the provider side, like what are the issues that they're facing, that they're struggling with, that are more regional maybe, or more systemic or institutional, so that we can kind of capture the different pieces of what's going on. Our goal is really kind of to figure out what we can do to help in some way, shape, or form, because delayed diagnosis is such a huge concern.
How much of this relates to implicit bias and stereotypes?
Those are definitely the factors that have the biggest effect, I would say. So for my schooling right now as a PhD student, I had to complete a project to do a systematic review, and I chose to do it on medical gaslighting. So I essentially had to gather up every article that's been written on this topic, read it, and kind of synthesize what the findings were. And one part of it was looking at kind of what are those factors that are affecting medical gaslighting. And implicit biases and stereotypes were the biggest thing that came across all of the articles, whether it was something that the authors were explicitly talking about or not. So a lot of this is just ingrained in the medical system, and a lot of it has to do with specific marginalized communities and minorities, especially women being the most common by far. So for example, this understanding, which is historical, of women being overly dramatic and overly emotional, and this idea of hysteria, which was a very common diagnosis back in the 19th century. And it actually dates back even further than that, where, the wandering womb and everything was related to like the reproductive health of women. And it all came down to, it's just psychological in nature. This has continuously been a thing for as long as we really can remember. And also another part of it too is that women and minority communities weren't even included in medical studies until the 1990s, which really is not that long ago. So that lack of education on not even just like, first of all, women's health and conditions that are specifically more prevalent for women, but also how are common conditions like cancer and heart attacks and diabetes, all these different things, how are they presenting in women and minority populations? We don't really have the data for that, because we know we've just begun to get information on like women, how they present with heart attacks, for example. It's a lot different in women compared to men, and a lot of women get dismissed because they're coming to providers and they're not showing the stereotypical symptoms of a heart attack because we don't have that knowledge. So that's a big part, as well as, like I said, the implicit biases and stereotypes, not just for women, but especially for a lot of Black patients. There's this stereotype that for some reason doctors believe that Black patients, they don't feel pain, or they feel a lot less pain than anybody else, especially white people. And so they're viewed as stronger, and they're able to kind of get through that pain more compared to other populations. So in this case, for example, like Black maternal health, this leads to women dying when they're giving birth because providers are just not taking them seriously, thinking that they're not really experiencing the pain that they're expressing just because of their race solely. And so this is a big deal. Like it's not just, delayed diagnosis, like Kendall was saying. It's coming down to like people are dying because of this medical gaslighting that is occurring, especially because of these implicit biases and stereotypes that maybe aren't necessarily taught in like medical school per se, but it's like a societal issue. We grow up learning these things and having these perceptions on these groups.
Have you found that there's an uptick in research into women's health problems, greater awareness that there's a lack there?
I'm seeing a lot more calls that are very strategic, that are centered around women's health conditions that are understudied. PCOS, for example, I saw something last year in CIHR, which is the Canadian Institute for Health Research, and they had a specific granting call directed toward women's health conditions that are kind of under-recognized or misdiagnosed. So PCOS, endometriosis, fibroids, like uterine. I'm definitely seeing more interest and investment in women's health, generally speaking, but it is still quite slow. With respect to PCOS, I could just talk about PCOS because PCOS is 1 in 10 women is the sort of point estimates. 1 in 10, 1 in 8 have PCOS, but up to 70% are misdiagnosed or undiagnosed, even though the diagnosis criteria is very clear, very, very clear. And so when you think about the fact that we're missing 70% of folks with PCOS, I did this deep dive into the kind of literature to look to see in terms of funding, like if funding is being allocated to PCOS. And I learned so through NIH, National Institute of Health, and through CIHR and through SURE, less than 0.1% of the research budget is going toward PCOS related kind of work. And of that like small, less than 0.1%, the majority of studies that are being funded are in relation to restoring fertility. So it's through like the National Institute for Child and Human Development. Like it's about making sure women can get pregnant, restoring fertility. It's less about the cardiometabolic impacts of PCOS, which a lot of women are quite concerned about. So PCOS is associated with things like heart disease, stroke, certain types of cancer, sleep apnea, non-alcoholic fatty liver disease. It's associated with all of these really like lifelong kind of comorbidities, yet the funding is disproportionately in this kind of reproduction, restoring that fertility angle, right? There was really, I think, in terms of the social sciences databases, there was one study that I found that was on like kind of the psychosocial impacts of PCOS, but more so in terms of like femininity and how like body image and those kinds of things. So and this was over the last like 10 or so years. I'm seeing an uptick, yes, with respect to kind of women's health conditions being more funded, but it's been slow and it's been focused on a very specific domain of health, which is reproduction. Like what Marissa was saying too, we're only recently starting to understand the cardiovascular impacts of PCOS, the mental health impacts of PCOS, what types of therapies work. I mean, this is all super new stuff that's coming out. And so it's nice to see, folks that are prioritizing, women's health. We still have a long way to go.
How can doctors learn to stop gaslighting patients?
We talk about listening with curiosity, listening with compassion, listening in a non-judgmental way that patients want. It's like what Marissa was saying, like they want to be heard, they want to be believed. But again, if you listen with curiosity, it shifts the focus. And we also kind of talk about this idea of cultural humility, or reflexivity, like Marissa was talking about. The cultural humility part is remaining humble and sort of saying, like, the patient who's in front of me, I don't know their lived experiences. I don't know what they're bringing into this conversation, into this room right now, into this space. And I need to listen to learn the context and learn the experiences. Think about this from, a holistic point of view. Like this person is in front of me. There's all kinds of things that they're bringing in. And so that's why Marissa really, in her work, focuses on the intersectional perspective, looking at all of these sort of pieces that kind of come together to help understand and really understand what's going on with that particular person. Because it's possible that the person in front of you, you're maybe the 15th person that they've seen. Patients, and even just from my own experience, I feel like it's my job for whatever reason to bring the burden of proof. So we've had patients in our data talk about bringing peer review articles, bringing data, bringing documentation, overly documenting. I remember reading one patient story where she took pictures of bruises on her body that just mysteriously presented. And she was very concerned about that and almost had to take extra photos to show the proof of that. Even before we get into that medical encounter, it's like we're ready for that.
It might sound very simple, but just listening is the biggest thing that we have read, not only in the responses from our study of patients that have, shared their narratives with us, as well as in the literature, is that people just want providers to listen. As Kendall mentioned previously, it's not about giving an answer. A lot of these women and just patients in general, they're coming to providers because they want to be heard, because they haven't been heard for a really long time. So just providing that active listening and, I hear you and I believe you. That's another big thing. It's like, I believe that this is an experience that you're going through. I'm willing to, listen and work towards finding an answer. Or, if I don't know the answer, I'm going to send you to somebody who I think does. So kind of letting down that ego of, I'm supposed to be the one who has an answer for you, and just providers just knowing that it's okay if you don't have the answer. We're not expecting you to know everything. You go to med school and you learn so many different things, but then you become a specialist in one certain area. I'm not expecting you to know everything, right? And then another piece of it too, I think, is that reflection on your own values, stereotypes, biases, because everybody has them. We all do. It affects our daily lives and just the way that we grow up in the society that we're raised in. So I think what a lot of providers should start doing is reflecting on, even just like after experiences and conversations with certain patients, like, did I have any biases or, these stereotypes or things that I'm bringing into this conversation that maybe were reflected in the way that I communicated with that patient? And how can I maybe change that moving forward when I speak to a patient with like a similar identity? So even just simple things like that, I think, can go a really, really long way. That active listening piece is the number one thing, because it's not always about having the answer. It's about just being there with the patient, being present.
One thing that I'm curious about is how can patients effectively advocate for themselves and challenge instances of medical gaslighting? Because in reality, they're the other person in the room and there's no support. What qualities can they demonstrate?
Some of our work really challenges that passive patient perception or passive patient narrative to say that, no, actually, folks are very assertive and it works. We've had folks talk about documenting refusals. So, for example, if a provider will say to you, like, no, I'm not going to do that test. I don't think anything is wrong with you. Well, can I have documentation of that? Can I have some of that information to take with you? Because then it's actually on paper that's documented to say you refused this potential investigative folks who are patient advocates. If you have to push and push and push, there's sometimes within a hospital like network, there might be an advocacy organization or a patient group that you can go to request additional support. Like within the PCOS literature, there's a lot of, like Marissa was saying, educational information online. One of those pieces of information is a question prompt list. So it's kind of this app. It's part of an PCOS app, but you download it and you can kind of put in like some of the questions or some of the domains you want to know, and it'll spit out this prompt list for you, which you can bring with you to the medical appointment to direct the attention back to you. We've had a lot of folks kind of talk about preparation part to say like, these are my questions and I'm actually directing the interaction, or making a list of things that you want to talk about before you go, like, again, to kind of push the narrative back toward you. Some of those things have worked. So a lot of it is around that kind of assertiveness, preparation, challenging kind of thing, and also around like bringing in advocacy and support groups. And I know too, when we've kind of looked at some of the PCOS support groups, there are a lot of strategies that women in those communities share with each other to sort of say, hey, this is what worked, this is what didn't work. And I'm in a rural community or I'm in an urban community where it's a larger center, and these are the things that worked for me. So why don't you try this? And it's kind of this empowering space. Like, you're sharing like tips and tricks and tools and strategies and tactics and things that can really help. And I think that's really great. And some folks will say, if that provider is not helpful, if the appointments are cut short or they're rushed or that person's being dismissive, has poor bedside manner, those kinds of things, find another provider. Like, just sort of grab your stuff, walk away and find another provider who will listen to you, that you trust and that you feel it's a true partnership, like they genuinely care for you. We recognize, though, that that's not always possible in communities that are, say, more rural, where you might only have access to a very limited number of providers. There's also movements toward virtual care, virtual conversations, because one thing we've found that's happening too is because folks so frustrated with like the medical system and the medical model, they're turning to alternative sources of care, and they're paying a lot of money. Some of it is great and evidence-based and helpful, like, naturopathic care. Some of it is not as backed by evidence, so it's like a bit murky. You have to kind of figure it out. But I mean, working with a great alternative or allied care provider has been helpful in some of these spaces as well. So these are some things that are it really coming up. At the same time, like, it's that alienation. Like you feel so alienated from the medical community and you lose that trust and that faith. And what happens is you stop going, right? Like you stop going to get your regular blood work, right? So we have folks with chronic health conditions that have said in our sample, like in our data, like I stopped getting my regular, screenings. I stopped getting my pap tests, all of these things because I don't want to go back there. I don't want to go through that again because it can be traumatic for folks who have had these experiences. And now I have to, go back and I don't want to do that. And so it's challenging because we could be missing something because, we're afraid to go back because it's been such a terrible experience. So these are some things we also consider around the empowerment sorts of things that we're finding too is like that distrust piece and how you want to do those regular checkups to see how medications are working, to see what's happening in your body. I mean, they're so important.
This has come up a lot in some of the research that we've done with PCOS, as well as in the review that I did as well of the literature. But the most common thing that's coming up is patients just being very assertive and persistent in the way that they communicate with providers. What I mean by this is continuously going to the doctor and asking for testing or for referrals or whatever it is that they may need, but often being very forceful and aggressive. It gets down to the point where patients have to change the way that they're speaking, almost become, aggressive or I don't want to say yelling, but, raising their voice. It comes down to the point where people have to kind of put their foot down and be a little bit more assertive in their needs. So that's one thing. Another part too is using those support groups online, we have found have been a really big help for a lot of people, not only just support groups online, but also just doing personal research that they can present to providers in the moment. So we've seen patients will show up with peer-reviewed articles to bring to providers. So for example, like if they're experiencing symptoms of Lyme disease, they're bringing in these articles that are peer-reviewed from medical journals talking about the different symptoms and the ways that these symptoms present in patients and saying, this is what I'm experiencing. So can we do testing that, goes along with these symptoms, because this is what I'm experiencing and this is what they're talking about in the literature. Sometimes it goes well, sometimes it doesn't. Like I know we had a patient participant talk about a doctor just like throwing the papers aside. Like they literally swiped them off the table and said, don't bring stuff like this to me ever again. But there have also been times where providers are very receptive. So I think it really depends. And I think it's definitely an option for patients, or even just coming in with that knowledge so that they can kind of rebuttal what the providers are saying and, hey, I do actually have some of this knowledge because I've done this research myself. And a lot of the times, like I said, that's looking on Google, that's looking in peer-reviewed articles, but also using these support groups for specific conditions like Lyme, fibromyalgia, endometriosis, PCOS, all of these contested conditions where there's other patients who are experiencing the same things. And the patients can kind of go back and forth in their experiences to kind of get an idea of what are other people experiencing, knowing that they're not alone in what they're experiencing, and then being able to bring that information to their appointments as well. We've even had some patients in in the narratives talk about like bringing men to appointments because they know that, it's obviously not the most ideal thing to do, but they know that providers are more likely to listen to them if they bring their partner, if they bring a male family member, the provider is more likely to take seriously. Like it's an unfortunate reality, but it has worked for a lot of people. And then I think that piece that Kendall brought up, the preparation is huge. Like a lot of people are literally writing scripts to bring to their appointments or tracking, like using logs. There's certain apps that you can use to kind of track all of the symptoms that you're experiencing every single day. You can track the severity, all of these different things so you can present it to your provider as proof of, I've been tracking for the last year that these are all of the symptoms that I've been experiencing every single day. So you have more to back up what you're talking about.
Where do we go from here?
Generally, we just need more research on medical gaslighting. So one of the big findings of the systematic literature review I did, while medical gaslighting itself, the phenomena is not new, this has been happening for a really long time. The actual term itself is new. The first article that actually ever used medical gaslighting in the academic context, I should say, wasn't until 2021. The actual use of this term is very recent. Like I said, we've had an understanding for a really long time of what medical gaslighting is. It just wasn't labeled in that way. There's still a lack of knowledge on what are the main contributing factors and mechanisms that are causing medical gaslighting. So kind of like that theoretical framework or just a general framework of what are all of these influential factors that are causing medical gaslighting and what are the outcomes of it. So there's a lack of research that's showing these things, right? And in order to make change, whether that be in the system, institutional, that is like a really foundational piece, is understanding what is causing these interactions. While we do, like, we have some idea, of course, like we mentioned previously, the implicit biases, the lack of education, but having a very solid kind of framework is helpful in being able to move forward in order to make those policy changes and working towards, better patient provider interactions. And then another piece of it too is in the research right now, there is a lack of provider perspectives on medical gaslighting. So in the review that I did, there was actually so I looked at 150 articles that described experiences of medical gaslighting, and there was only 13 of them that had provider insights on medical gaslighting or just like patient provider interactions. As we know, there are influences from the provider perspective, as we've talked about in the Canadian medical care system specifically, right? That lack of just being overburdened in the medical system, the lack of education, what are they learning in medical school? What are those, like, are they being reflective in medical school? Are they learning about implicit biases? Are they learning about the patriarchal influence that medicine was built on? We don't really know these things, and knowing what is impacting the patient-provider interactions from the provider perspective. So I think also having research on that avenue, getting the provider perspective, it is going to be a little bit tricky on like, how do we word this? We don't want it to come off as blamey where we're, interviewing providers or talking with them and saying, why are you gaslighting patients, right? It's what are the ways that these power dynamics or, your expertise in these field, how are these influencing your interactions with patients? Like, we have to really frame it a certain way so that we're not coming off as, blaming the provider for all of these problems, right? So just generally more research on medical gaslighting to kind of understand what are those big influential factors that are causing it and what are the big outcomes, because a lot of it is patients questioning themselves, doubting themselves, worsened health because they're not getting the treatment that they need, can lead to death, like all of these things, right? But having a very solid foundation of what are these factors, what are the outcomes, and then also what's going on from the provider perspective, I think those are the avenues of research that we kind of need to focus on in order to actually implement change. So I think there are definitely some policy implications that we can pull from what we currently have in the literature, but I think it will definitely be better grounded if we are able to kind of do research in that area.
How can medical professionals work to deconstruct their own implicit biases?
I think that reflection piece that we talked about is just like, that's the thing that jumps to my mind right away. Being willing to reflect on your values, your experiences, your standpoints, kind of what you believe in, I think is the biggest thing, right? That's how we are able to move forward and make change. After you have an interaction with a patient, even if it is, a white heterosexual male, think about, what perceptions did I come into this interaction with that might have affected how I talked with this patient, decisions I made, and how can that maybe be different the next time I work with this patient? And then kind of slowly integrating that into the way that you, after your conversations and interactions with all patients, right? Like thinking about, what did I come into this conversation with, and how can I maybe change that? Or were there some kind of biases? Were there some kind of perceptions that I had over this person because of the way that they look, the way that they talk, the way that they act, right? So I think just slowly adding that reflection piece into even just in your daily life. Like, it's not even just about the medical interaction, because if we're going to continue doing that in our daily lives, it's going to then affect our workplace. It's going to affect other areas of our lives. So I'll add to that, adding that reflection piece in your interactions with anybody, with your friends, with your family. Then if you're able to make those changes in your day-to-day lives, then you're going to be able to make those changes easier in the way that you interact with patients within your job. We're not going to get anywhere if we're just kind of targeting providers as the bad guys, right? Like, they're not going to want to change. If somebody was telling me I'm doing all of these bad things, I'm like, what are you talking about, right? Building those bridges, like Kendall said, is so important if we actually want to make real change within the system. It's not going to work if we're just, like you said, polarizing and having these groups like, we're with the patients, but it's about the providers too. It's about the quality of, making their workplace better for them and making them feel like it's okay for you to make mistakes and it's okay for you to be wrong. Like you don't need to know everything, it's okay to not know. So yeah, I think that's like the most important part about moving forward with this.
Like what Marissa was saying, I completely agree. And we've had, these conversations, and I think we need to build bridges and partnerships and get at, the multiple dimensions of medical gaslighting from multiple perspectives, because we really do want to kind of forge those connections and those relationships, because at the end of the day, like Marissa and I are psychologists, right? And we're studying this phenomenon that a lot of people are talking about, and they've talked about it in the popular media for a very long period of time. And we're sort of trying to look at it from an academic evidence-based, perspective. So we have our own lenses and our own backgrounds and our own, disciplinary stuff that we bring to the table. I think a lot of it has to do with, building those relationships. So we have medical providers who are champions of this sort of cause and who within their own communities are amplifying conversations around communication styles and strategies and implicit bias trainings. And Marissa and I have this kind of exciting, like, oh, let's go into the medical school. Like, let's get them when they're in their first year and they want to save the world. Let's do all of this implicit bias training and let's infuse it throughout their curricula. And we're doing this from our psychology point of view. We have no idea how this would actually translate, into the medical community unless we have a true partnership with folks within the nursing community, within medicine, to sort of say, okay, let's come together and come up with solutions that are co-constructed and built like together, right? Versus us from our kind of semi-outsider perspective, right? And I think the future of medical gaslighting is going to be interdisciplinary. It's going to be team science where we're working together to figure this out. It's going to involve multiple stakeholders, from patients to providers to caregivers to, like organizational folks to advocacy groups, like I think it's going to be all of us united rather than siloed to really figure this out. And again, everybody I think has a stake in it. I think everybody would be like, oh, 100%, I want my patients to do better. I want my patients to have better outcomes. I want them to be better informed. I want to improve health literacy. Like I see, that's what Marissa was talking about, the intentionality part, right? Like we don't really think that really has anything, we don't think it's intentional. We think that everybody really does want people to thrive and to feel well and to do well. And I think we need to start having this conversation. That's why we're so excited to talk to you today and to really talk about the work that you're doing within your advocacy group. We did see, patients with Lyme disease, long Lyme, for example, also represented in our data set as well. As we're kind of going through it, Marissa can probably speak to that a little bit more, but this is something that transcends like so many things. The Lyme experiences are quite unique as well, but I think also really illuminate like a ubiquitous, widespread problem that we all, again, to reiterate, need to really come together to tackle.
Thank you both for your time today. Your work is fascinating and important.
Thank you for letting us have this conversation. We're always so excited to talk about this work. We understand that it's obviously very heavy and it affects both of us in our own personal lives too, right? That's another hard part of doing this research. Like every woman that you talk to, I guarantee has had some sort of experience like this. I know Kendall has, like everybody really in our research team, right? So that it can be difficult to navigate these conversations, but we're still just so passionate and excited to be able to do this work and have these conversations. So thank you for having us as well.
Make sure to tune in next time as we engage with more experts from Canada and around the world.